Asmita, shall I start?
Yes, you can start.
Okay, thank you. So good evening to all of you. I'll show a short case first, then followed by two long cases. Can you see my slide?
Yes, sir.
Yeah, okay. I will do that. Okay, this is a story of a 19-year-old nursing student. She presented with inability to lift both hands for the last 2 months, difficulty in 5 movements with the hands of 2 months duration. There was no pain associated with weakness, no root pain, no sensory symptoms, and the complaints are subacute in onset and gradually progressive. Recently, she was detected to have thyrotoxicosis and is on minomorprazole for the last 1 month. There is no preceding history of fever, vaccination, no history of any rashes, ulcers, joint pains, no significant past history. Next time, there's no video here, only the photographs I will show. Next time, cranials were normal. There was weakness and wasting of extensors of the wrist, extensor digitorum, extensor pollicis longus, abductor pollicis longus, and thenar muscles. If you look, the pattern is more in the distribution of radial and median. However, there was mild weakness of interossei and hypothenar muscles and adductor pollicis, but they are much less affected compared to the other muscles mentioned. So the other muscles are all normal. Proximal muscles are all normal. Deltoid, biceps, triceps are all normal. So, in fact, the distribution was marked weakness, the distribution of radial and median nerve bilaterally with mild ulnar nerve involvement. The weakness is asymmetrical, more on right side compared to the left side. The professor all normal, no sensory deficit, rest of the neurological examination normal. This is the hand of the patient. It's got a bilateral wrist drop, wrist and finger drop. And this is the palm. This is you can find mild wasting of the interossei in the interossei thenar muscles. You can make it out there. And this is how she was keeping his hand, and when you lift up the upper limb. So, what do you think is a localization and likely diagnostic inspection?
Pure motor element syndrome, sir.
Very good. So, what do you think what is likely pure motor?
Split hand syndrome. Split hand sign is present, sir. Thenar is more involved than hypothenar, sir. So motor radical anterior horn cell.
Okay, very good.
Possible.
Motor radical anterior. So why not nerve involvement? Motor nerves involvement.
Motor nerves, sir. The distribution is in the pin as well as median nerve distribution, but median sensory is not there, sir.
No sensory is not there. Sensory is totally absent. So,
Yes, sir.
But even if you find that if sensory is not there, if the pattern of weakness is the distribution of the nerves, you have to first consider motor neuropathy rather than anti-constant disease. The constant actually patchy involvement. If the distribution is favoring that, even if the sensory is not there, you have to think of a motor. There can be multifocal motor neuropathy, or some kind of vasculitis, can predominantly motor and sensory. SNAP may be absent on a electrophysiology. So that should be the best possibility. Okay, so this is the multifocal motor axon variant. That is the possibility I considered. Both upper limbs are affected, lower limbs are all normal. So these are the two possibilities considered: multifocal motor neuropathy and vasculitic neuropathy. Okay. So what investigation do you require now?
NCS, sir.
Okay, NC is a short case. So this is the other possibility, as you said, could be anti-constant because pure motor, but being subacute and onset with relatively rapid progression like that, it is more likely to be a multiple motor nerve. So NCS was done. The decreased EMAP amplitude from both median and radial nerves bilaterally, right more than left. There was normal velocity and no conduction block. There is no demyelinating picture. SNAP was normal. So it's a pure motor axonopathy. Lower limb conduction normal. So motor neuropathy, axonal variant, this is the possibility. Okay. What else you want now? So we confirmed. Pardon?
Anterior hair console involvement to be ruled out.
Yeah, that can be considered, but the pattern was more in the distribution of the nerve pattern.
Can look for an EM.
Yeah, still multiple motor neuropathy has to be considered, no?
Inching, sir.
Yeah, right. So that inching is applicable only compressive neuropathies. When multiple nerves are affected, inching is not going to help us. So investigate for the cause of multiple nerve. So blood routine ESR was done normal. Metabolic profile normal. Thyroid function normal. Vascularity workup negative. CS was normal. So what does he like to do?
Sir, proximal studies were done in nerve conduction.
Yeah, no, they're all normal. Only the affected nerves were these two nerves. The involvement was only in the distribution of those nerves only. Other nerves are all normal.
Was Anga done?
Yeah, Anga was also done. Along the vascularity workup, Anga Penga was also done.
We should be doing an MRI.
Pardon?
MRI should be done.
But MRI, why? Because the distribution of the nerves, no? MRI is not going to help us.
Treat the patient, sir.
Pardon?
We'd start treating the patient.
Right, yeah. Because ideally, a biopsy should have been done. But because of the facilities not available at that time, it was not done. So these are the things you considered: multifocal motor neuropathy, axonal variant, non-systemic vasculitis of peripheral nervous system. So patients given IVAG and patients continue. He was already on treatment, neomarcosum, and patient was discharged. She did not improve much, mild improvement only. After 1 month, she presented with burning pain in both the lower limbs up to the knee. This time, sensory symptoms appeared. And there was right foot drop, weakness of the right foot. However, there is no worsening of the upper limb weakness. No other positive history. So, an re-examination showed mild weakness of the dorsal fascia of the ankle, peroneum on the right side. At this time, there was a sensory impairment in the distribution of the peroneal nerve. So we know now it's certain it is a multiple nerve, but sensory nerve also is getting involved. Upper limb weakness remained the same without any sensor. Rest of the neurological examination normal. Again, repeated, conduction was repeated. Now there is, in addition to the previous finding, there is low CMAP amplitude from the right conperoneal nerve, tibial nerve, as well as the left tibial nerve also is decreased CMAP amplitude. The snap was absent in the right sural nerve. Conduction velocity remained normal. So again, now we change the diagnosis. Instead of motor variant, we consider axonal variant of sensory motor neuropathy. So what will you do now?
Any skin lesions, sir?
No skin lesion, no skin lesions.
Thyroid antibodies were checked, sir.
Thyroid antibody, I do not know. I don't remember to we have done.
Give steroids.
Okay. So that's what we did. She was given IV methylprednisolone, and then because of the burning pain, started on carbamazepine and amitriptyline for the burning pain. After 3 days of starting treatment, she developed severe abdominal pain and recurrent vomiting. She was suspected as steroid-induced gastritis. So started. Pardon?
Orthobilinogen urine PBG.
That has to be considered, correct. So started on H2 blockers and pain and vomiting increased. So gastric consultation was taken. He did OGD normal, used abdomen normal. Next day, patient became drowsy, tachycardia, persistent pain and vomiting, serum sodium was low, SAADH. So what was this test done?
NMO, sir.
MRI, sir.
MRI, no, pardon? Yeah.
Porphyria.
Porphyria.
Okay, very good. All of you are correct. Severe abdominal pain, vomiting, encephalopathy, SAADH, external neuropathy, porphyria. Urine sample collected on storage, high urine color. Repeatedly, urine porphyria was positive. 24 quantitative urine sample porphyria 4 plus. And this is the color of the urine. So all medicine stopped, started on high carbohydrate diet, glucose infusion, and vomiting abdominal pain disappeared in 24 hours time. We could manage to get in 48 hours, she was asymptomatic, pulse normal, sensory symptoms improved, weakness. However, the weakness did not improve. Hemat inhibition was given. There was mild improvement in the weakness. And follow-up, she was asymptomatic, but weakness and wasting the upper limb was persisting. Lower limb became normal. That came later that it became normal. Siblings and parents were screened, they were normal. So that's the story of the patient. So porphyria can sometimes present pure motor neuropathy to begin with, like a bilateral wrist drop. Pardon? Monsare Parnio? Hello?
Nothing, sir.
One other possibility is a lead neuropathy, which can present with motor weakness and abdominal pain.
Exactly. Yeah, lead also can, because the basic physiology almost the same. No, it's also the porphyria is also lead also producing effect in that pathway.
Can it
That
produce
can also
so fast? When lead will it affect so fast? This is like a subacute.
No, in fact, only I have got a textbook knowledge of pure motor neuropathy. I have not seen one case of lead neuropathy at all. Have you anyone seen that? The book always mentioned that, but nobody has ever seen. I have never seen one.
So any correlation with the thyroid and neomarcosol?
No, they can worsen porphyria. That is why she become symptomatic. See, neomarcosol is a drug which can clearly worsen precipitate porphyria. The second thing we added carbamazepine. That also precipitated the worsening of the porphyria in this patient.
One other thing which can happen with neomercosol can cause a secondary anchor vasculitis, and that can also produce mononeuritis symptoms.
Right. Okay, shall I go to the next case?
Yes, sir.
It's a long case. It's an interesting problem. It's a 47-year-old man. His complaint started 2 years back as pain in the central low back region with no radiation down the leg, which initially subsided with treatment, and probably an analgesic treatment. 3 months later, he noticed heaviness of the right lower limb with difficulty in pushing the limb forward, which was gradually progressing. 6 months back, he noticed pain and swelling of both angle region. Along with that, he also noticed heaviness of the left lower limb with difficulty in pushing the limb forward, just like the right lower. For the last 3 months, he noticed recurrence of lower back ache as well as pain over the both hip region. His main problem was backache, hip region pain, angle pain. Angle pain came later, and he says he's got a stiffness of the limb, making it difficult to push forward. There is no other sensory complaint. The pain was not suggestive of the root pain. So this is the video of the patient. See how he is walking. Very difficulty in walking, pushing his forward. So has to climb onto the coat. See the time taken to climb onto the steps. Very difficult to make him come. The severe pain he has. Failure examinations were all normal. There is no spasticity of the limbs. Power was normal in the upper limb. They see the difficulty in getting the limb onto the bed. The way he lies down, he got a severe pain in the back. Whenever I tried to do the tone, he was screaming with pain. Power was normal, even that he was cooperating, power was normal. Expression normal, EHL was normal. The only weakness I got was abductors was normal. Adduction was normal. Reflexes normally elicit in the upper limb. Knee jacks were normal. Ankle jacks were absent. Even with reinforcement, it was absent. Knee jacks were however elicited. Plantar was downgoing. Flexor were normal. The only weakness I got was adductor hallucis was weak bilaterally. Sensations normal. Vibration normal. SLR, see when you bring the leg down, he was screaming. Just the opposite of SLR. See when he's lifting up, you no pain. When you bring it down, hepatic test was negative. Hip rotation was also normal. On checking the back, his sacroiliac, there is mild tenderness on the back. And this is how you walk, to get up and walk. He is asked to stand on toes and heel. Thrombus was negative. He could stand on heel, he could stand on heel. But toes, he could not stand on toes. Okay, I'll summarize the findings. Cranial normal, motor system, his mind is confined to both the lower limbs. Prone grossly normal, but walks with stiff legs, which I already seen. For all normal when examined in the bed, except for weakness of adductor hallucis. Power of EHL, FHL were all normal. He could not walk on toes. DTR all normal except for both ankle jacks, which were absent. Sense system normal. SLR negative. However, he complained of pain when the legs were brought down from the lifted position. Hepatic test was normal. There is local tenderness over the lower back. Gait, he walks with stiff legs, gait difficulty in getting onto the coat and lie down, probably because of the severe pain. So what is a likely possibility?
You have to exclude a paraspinal pathology, sir. In view of severe pain and
Yes.
tenderness in the low back, sir.
Correct.
Any arthritis, infection, or discitis, or any.
Correct. But the only objective neurological finding is absent. He is not a diabetic. And he could. Yeah, that's a good. Stiff person syndrome is a good possibility. But they will not complain back pain. They can complain of back pain because the stiffness of the back. Very good. They can complain of back pain. But pain here is more bringing down the lower limb. That is a complaint he told. And again, absent angle check was that plantar flexors was weak. I mean, he could not stand on toes.
Been L5S1 radiculopathy and
Yeah, that's also we have to keep in mind because he was because all other reflex cerebellar is not a diabetic and plantar he could not stand on toes. So I considered one this possibility bilateral S1 radiculopathy.
Could be due to severe pain in the back, no, sir. He can't be able to stand because of pain in the back.
But he could stand on toes and stand on heel. You lift up his toes, but he cannot stand on toes. If that is situation, you don't be doing the other thing also. No. Pain, of course, is there. Severe pain. That I agree with.
But lying on the bed of power is good now. So plantar flexion.
Yeah, but that often, no, that is, you can relate on. Always you have to check the motor power on active standing. This I had done many times before. Apparently normal power, but making on heel or toes, the weakness appears. So this is my first two possibility thought, bilateral S1 radiculopathy versus a local spine problem as you are thought. So what do you want me to do? What would you like to see?
MRI, sir.
Okay, MRI, the less spine, correct. This is the MRI, the less spine, T2 weighted. Normal. This is the T1. This is the T2 axial. This that took a thin T2 thin cut also was taken to find out any root compression. The roots are all perfectly well clearly seen. No root compression at all. You can see the roots very clearly. So MRI cervical, anyway, they took MRI cervical spondylosis, they're also normal. So what do you want now?
big contrast scan.
Contrast was not done.
CT, sir. CT of the spine.
Yeah, that was done later. That is normal.
What about sacroiliac joints normal?
Okay. That's a good thought. So what I did was I want to explain the weakness of the limb. So I did an NCA study also. NCA study showed decreased EMAP amplitude from both peroneal nerve, more on the right side. But tibial was normal. Sensations normal in both sural and superficial peroneal. And right peroneal FA was ineligible, probably because of the low amplitude from the right peroneal ED. So how do you explain this decreased EMAP amplitude?
H reflex to exclude radiculopathy.
Yeah, that's what S1 radiculopathy, but S1 was normal. So I did an EMG of the paraspinal to find out when in EMG in the paraspinal muscles that was normal.
Sensory were normal. Huh?
Sensory was normal. Snap was normal. That is why I did a paraspinal EMG.
Do a contrast MRI scan and also SI joint.
SI joint. Okay. Okay, now I thought more likely is going to see some local pathology in this pain. That is, I thought initially my esondadiclopathy was not convincingly proved after examination, investigation. So the years this investigation is done, see the count 24,370. Then 4 days later, 17,170. So I did these following tests. ANA profile was done, that is negative. This already showed. Then alkaline phosphatase is mildly elevated, amount 315, and normal range was 38, 126. CRP was less than 5. CPK normal, calcium is normal, LDH also normal.
What about other LFT, liver function?
They are all normal. That I did not show. All other blood parameters normal. TCDC, ESR, other LFT, RFT are all normal.
Peripherals means, sir.
There is also normal. That I am going to show. I am going to show normal.
Workup for myelomas?
ESR is only, how much is the ESR?
3.
3.
Was only 3.
Brucella.
Yeah. Brucella, okay. Right. So there is Brucella, but some changes in the MRI for severe back pain. It will change in the MRI.
Peripheral CMA was normal. No?
Normal. I'm going to show that. Okay. This is normal now. So thyroid function is normal. The Doppler study, this I did not do some. So I was not sure what is going to happen. So I was examining in the ward. Then I found out that he's actually no real weakness of the plantar flexion. When I touch plantar flexion, completely severe pain in the ankle. Sorry. So he's got a pain in the ankle joint. That is why apparently appeared like a plantar flexion weakness. But ankle continued to be absent. That is baffling me. Probably this decrease came up or maybe due to some edema or some local problem, maybe technical.
What was phosphorus and magnesium levels?
Yeah, very good. I'll come to that. Very good. So this is, I'll tell you the evolution of what I did. So then I examined the back to find out any sacroiliac PR tenderness of the sacroiliac joint. So that time I said,
like osteomalacia.
Yeah. So osteomalacia, but there is no changes in the bone. Calcium is normal. The CT, then I did. So I wanted the ability can be due to the ankle joint problem, but it's ankle except absent ion reinforcement, and he has got tenderness over the SI joints mainly on the left side. So MRI of the SI joint and hip joint were taken along with followed by CT cut was also taken. So this is the SI joint. I'm not good at interpreting SI joint lesions, but reported they're normal. Still sequence will also find out in pathology. There is no abnormality in the SI joints. Then still sequence, this and the still sequence is done. Then anyway, we are taking the joint, the hip joint also was asked to take. That also is normal. So there is no hip joint pathology nor SI joint pathology. This is a report, an SI joint normal morphology. So CT was also taken, which also did not show any bone erosion in this joint.
Such severe pain and increased alkaline phosphatase, I think you should do phosphorus also. Because
Correct.
calcium can come as normal, I think, in some patients.
Okay. Which condition you have given, any possibility have in mind?
Something called oncogenic osteomalacia, which can produce very low phosphorus and severe pain.
Okay. Very good. Very good.
Sir,
So
CT
anyway,
of the dorsal spine was not done, sir. In the first
Pardon?
video, he had tenderness in the dorsal lumbar lesions around D10, D12. The
So that
tenderness
was
and
also done. The
MRI.
MRI, that also done. I did the MRI dorsal spine as well as the
CT of the dorsal spine because an erosion or any arthritis.
No,
Because
in
most
fact,
cases of
the
present.
CT screening was done, the lumbar region. I did not do it in the upper part. There was no tenderness over that area, dorsal area at all. It is only in the lower part.
In the first video you showed, he was screaming when pressed at the dorsal lumbar.
No, that's only when you was lifting up the pain. Pain was always the lower part. So that's a little clear. Yeah,
PET scan, PET scan.
PET scan, PET scan, whole body PET, FDG PET.
Whole
To
body.
find out whole body PET for paraneoplastic syndrome.
Yeah.
No bone erosions or any arthritis.
No, but we have to first document where the lesion is, no? We have to account for the pain, what is causing the pain, and then go for the PET scan we can do later on. Because there are so many PETs now, FDG PET, other PETs and all, they are available. We have to choose which is required in this patient. Okay, then I took my hat off. I said I couldn't make a diagnosis. So I sent a consultation to the physician. So he did these tests. Anti-CCP antibody, that is negative. HLA-B27 was negative. RA factor, they're all negative. They need a parathyroid hormone versus high, 195. Normal was 65. Now what is the diagnosis?
Hyperparathyroidism.
Okay, hyperparathyroidism. But calcium was normal.
Can have normocalcemic hyperparathyroidism is there.
Okay, right. So then this is the repeated the calcium again. Calcium was 8.7 only. So in fact, the physician thought it is hyperparathyroidism. So he also asked for rheumatology opinion. Rheumatology said that this cannot be hyperparathyroidism because primary hyperthyroidism calcium should be elevated. Without elevated calcium, it cannot. That is his version. Anyway, PTH is high. So then again, physician also left me. Then he said to consult an endocrinologist. So then the urine calcium was checked to find out whether there is a calciuria is not there. That's also normal. So physician opinion, he considered the possibility of hyperparathyroidism with elevated alkyl phosphatase and PTH, even though calcium was normal, as Joy was telling. So he was advised MIBB scan. MABI scan to rule out parathyroid. I'll tell you what, I did not know about this scan before. I'm hearing for the first time. I'll tell you 2-3 sentences about this scan. So this parathyroid imaging was done. No definite scan evidence of any focal MABI, avid hypermetabolic lesion in the neck or visualized mediastinum to definitely suggest a parathyroid adenoma in this study. So there is no parathyroid adenoma.
So till now phosphorus is not done, sir.
I'll come to the Joy. Joy is itching for phosphorus. I'll give you
Because
this.
calcium, phosphorus and all we do together, no?
Together, correct. In fact, frankly speaking, I did not do the phosphorus. Physician also did not do the phosphorus. But you are right, I'll come to that later on. Now tell me, what is this MIBS? And I'll tell you 2 sentences. Here is a radioactive substance called technetium 99M sestamib. That's called MIBB. Is injected into the body. This is absorbed by the overactive parathyroid mitochondria, and gamma camera picks up the images. What is its usefulness? Useful to identify parathyroid adenomas that cause hyperparathyroidism, identify persisting parathyroid tissue in patients with recurrent disease, localize active parathyroid tissue before surgery. So the endocrinology consultation was done. See the peripheral smear. Is it vitamin D done? It was low, but many people know vitamin D be normal. PSA was normal. Repeat the parathyroid hormone, which is little more high now. It is 213, initially it is 195. This is the blood parameter, as Leopold is normal, ACA normal. Phosphorus is 1.4, as Joy was telling. Phosphorus is decreased. Calcium normal, phosphorus decreased 1.4. And what did you like to do?
Hypophosphatemic rickets is a possibility.
Pardon?
Hypophosphatemic rickets or vitamin D deficiency is also.
Yeah, right. Vitamin D can produce hypophosphatemia. So there is also vitamin D is low, but I'm not very much convinced vitamin D. Many patients you send vitamin D is low. Whether it is significant or not, I don't know. Anyway, what your point is well taken. That is what endocrinologist also told. So ultrasound abdomen, endocrine opinion. He said metabolic bone disease, hypophosphatemia, secondary hyperparathyroidism. He is telling that low phosphate can also produce secondary hyperparathyroidism without calcium. Clinical picture favors hypophosphatemic osteomalacia. Next step is to rule out phosphaturia. However, this can be done only after supplementing vitamin D. That is what his opinion written the case sheet. So he was put on vitamin D and asked to come up after 4 weeks. This is his report. So patient discharged on vitamin D, and 4 weeks later he came back. This time his pain is less but not totally gone. Even after 4 weeks of 4 to 6 weeks of vitamin D, but much better than walking is better. He could climb a little more easily. I checked the power of same angle check. Again, the angle check continued to be absent. His angle joint was painful. Initially, you can be screaming with pain. That pain is not there on bringing the arm downward. This is second visit. Pain is much better. Walking is still slow and stiff, but better than before. On bringing the legs down after SLR, there was no pain. So the repeat serum phosphorus was done. That is 2711. That is 4 weeks after the first one. The phosphorus was 1.6. Parathormone is came down. The initial serum phosphorus was 1.4. Now it's increased to 1.6 after vitamin D. Now the initial PT is at 230. Now it has come down to 159 just on vitamin D.
Wasn't he given phosphate supplements?
No, not at this time. No, he was at this time. He was given the second time. And after this, he was given phosphorus. So this is 3. The initial was on 2711. And another value was done on 1312. At that time, he was given phosphorus on 2711. Then he was put on phosphorus also. Then the parathormone remained 140 and serum phosphorus is 1.7. So patient was given phosphate supplements. So third visit was on January 25th. Then the angle checks were continued to remain absent. Power was normal. Other rest of the values are all normal. And look at the gait now. There was again no much pain. There is no pain now. He could walk a little more better than before. Now he's able to lift a little bit. He's able to stand on toes a little bit because the pain must have subsided now. On third review, walking is better, no pain, can stand on toes a little bit. Then repeated the serum calcium 25, 125. That is phosphorus became 2, that is the last value. Serum calcium went all throughout and parathormone became again lower than before. So this is the evolution of the values. 711 before vitamin D, PT is 213, phosphorus 1.3. After vitamin D, PTs came down phosphorus increased 1.6. After adding phosphate, pH again became low and phosphorus became 1.7. Continued the same treatment. pH further became low, and phosphorus become almost normal. It's not normal yet. This is the value with adding these two things. Now, what else you want to do? Now, next the question is, why should you have this low phosphorus? Anything else you like to do? Anyways, Joy was suggesting the serum was sent for fibroblast growth factor, which is a predictor of paraneoplastic syndrome causing secondary hypophosphatemia. There's a mesenchymal tumor. I did not know any of these things. Only the endocrinologist is teaching me all these things. I thought I will share this information with you. So this was
What was
done.
the urine calcium? 24 urine calcium. Sorry,
That is
phosphorus.
not
Phosphorus.
that phosphaturia, some or other that I did not, because he was under the follow of the endocrinologist. Some or other I did not see that report. In fact, I wanted to see the phosphate in the urine also. That report, I was also looking for that. That is not there. It must have been, I do not know, it must have been elevated there. Now look at this value here, this fibroblast growth factor, 360. Again, a very high fibroblast growth factor, 23. And he was of the opinion that if you find this so much elevated, it's most likely is having an underlying
tumor.
yeah, tumor, mesenchymal, which may be benign, but it's producing this particular. So that, and two sentences about fibroblast growth factor 23. It's a protein which in humans is encoded by the gene. Is a member of the fibroblast growth factor family, which participates in phosphate and vitamin D metabolism and regulation. Main function is to regulate phosphate concentration in the plasma. It does by decreasing the reabsorption of the phosphate in the kidney, which means phosphate is increased in the excreted in the urine. Is secreted by osteophytes and responds to increased calcitrol and phosphate. Now, this is an important factor. This can also be produced by or produced by some certain types of tumors, such as benign mesenchymal neoplasm, phosphaturic mesenchymal tumor causing tumor-induced osteomalacia, a paraneoplastic syndrome. So, what you want to do? Not the ordinary scan, gallium PET scan was done. That is a scan required to find a mesenchymal tumor, not our ordinary FDG PET. So, the fourth visit on 25/2, while on this thing, is much better now. He's walk very almost freely. See the first walking and this walking. Still is abnormal, but much better than before. He's only on vitamin D and phosphate. He could get up without any pain, could easily get onto the cot. And other things were all same. Hangage continued to absent. There was no pain now. So result of the gallium scan, no definite evidence of somatostatin receptor positive disease anywhere in the whole body surveyed to suggest malignancy. Now this is the gallium scan. And he was put on phosphorus and drug calcium. But he was of the opinion that this is going to be mesenchymal tumor. Somewhere maybe a small tumor somewhere which is eluding us now. We have to do a repeat PET CT after 1 year. It's a paraneoplastic syndrome. Mesenchymal tumor may be a very small one, which it can be easily missed. So this is the story of the patient. In fact, Joy picked up this case from the very beginning. He asked for the phosphate and he thought it could be a paraneoplastic. That's the condition here. I have never seen one before.
It's called oncogenic osteomalacia.
No, I was sounding making.
That's called oncogenic osteomalacia.
Yeah, oncogenic osteomalacia, correct.
Sir, when was FGF 23 done, sir? Fibroblast growth factor 23, sir?
I don't know much. I only know about this information. This also got it from the literature only. I have no idea. I'm hearing for the first time.
So usually in a downbeat nystagmus, we say that
Previously
FGF
such a
23
patient,
I don't know.
there was previously such a patient
Yeah.
while I was in Amarda. This patient was getting treatment as motor neuron disease, probably because the severe pain is not able to walk, and probably the muscles, because the disease thing, it got wasted. So everybody was thinking in terms of motor neuron disease, but this pain was severe, and workup showed this high alkaline phosphatase and calcium was normal, phosphorus was low, and he had this tumor in the near his tibia, one small tumor near the tibia, and that was taken off and he became completely normal.
Correct, exactly. That is our integrals also vehemently telling, sir, there is got to be some tumor somewhere that is evading us. I'm going to do repeat MRI, this thing, PET scan after 1 year.
So bone marrow or total count repeat, peripheral smear, lymphoma workup, sir.
No, we already know the diagnosis, and responded very well to treatment also. And other things, ESR was normal, peripheral smear was normal. I think the system myeloma in this patient. And MRI and CT did not show any osteolytic lesions.
The initial white cell count was very high. That was
very high.
I thought something will be there with the white cell count.
Also, I was not able to explain. That is why I sent for all the blood investigation initially. Okay, any questions before
It's
I go
always
to
better to do phosphorus along with calcium all the time.
Calcium, correct. But it's
always better to do phosphorus along with calcium.
Calcium, yeah.
And it is one of the best diseases to treat, osteomalacia. The pain will go away with necessary supplementation.
Yeah, right. Very gratifying results will be there. Correct.
Sir, why white cell is elevated, sir? TLC count reasons?
No, I don't know. I don't know. That you have to check.
Bone marrow would help, sir. Bone marrow.
Bone marrow is not done.
Whether it could have helped the diagnosis further, sir?
No, it will not help. No, because we found that it's got a metabolic disease, metabolic bone disease. So we have to work in that way. As I was telling, calcium phosphate, alkaline phosphatase, and that way you have to go. Vitamin D, that level. Parathermone, that whatever hormone is involved in that calcium and phosphorus metabolism, that line you have to look for. There is no
leukocytosis. I mentioned severe stress and pain in some patients can cause considerable leukocytosis. That's mentioned.
Right. Name. In fact, this patient was initially considered functional from the previous hospital because he got severe pain. Nothing is found in the abnormality. He was thought functional. But the blood count was always elevated. I should have thought that this is not, it never can be functional. Okay. Shall we go to the next case? One more case.
Yes, sir.
Right. So, this is not a medical case, it's a neurological problem. So this young man was referred from the psychiatry department for the complaint of severe pain in the left leg and inability to walk. In the past, he underwent treatment. He was under treatment at the de-addiction center for the last 2.5 months. He was totally knocked out, was violent, agitated. After about 1 month after admission to the center, patient noticed severe pain in the left thigh, followed by difficulty in walking. He was admitted in the psychiatry ward after the de-addiction study came to the hospital, where he was admitted in the psychiatry ward and then referred to us to routine neurological problem. Okay, so he was going back to the history once again. In fact, he was admitted in the psychiatry ward. From there, he was referred to the neurology opinion to find out the reason for his pain and weakness in the left lower limb. But this is a past history. He was in a de-addiction center for 2.5 years, 2.5 months. After 1 month of treatment in the de-addiction center, he was admitted in this in the hospital, medical college, and he was referred over here. Now, this is the video of the patient. Upper limbs are normal. He's got weakness of the hip flexion on the left side. This also is weak, but he was coming with severe pain in the thigh. What is weak? EHL dose angle normal. Plantar flexion normal. Adductors of thigh were normal. But he was not holding on the left side because of the pain. Abduction was normal. There's a pain there. Left knee jack was absent. Right knee jack is present. Both angle jacks are normally elicited. Plantar was downgoing. No calf tenderness, but he was got severe thigh tenderness. Not on the hamstrings. Cordyceps was tender. Is same. It is decreased in the leg, middle part of the. Their area is decreased. That is normal. You will tell it become normal. There it is normal. This become normal. In the middle part of the leg. Vibration normal. Check that adductor once again. See, it is normal. Initially, he did not do that because of the pain. Femoral chest is also painful because thigh tendon is also there. So, on examination, findings confined to the lower limb. No wasting of any muscles. Severe tenderness in the left thigh. Power weakness in the left quadriceps. Weakness in the left hip flexors. Other muscles normal. Left knee jack is absent. Other DT are normal. Sensation impaired pain and touch in the left medial leg. So there is a localization.
Femoral neuropathy, sir.
Yeah, it's a typical femoral neuropathy. And it's got a severe muscle tenderness, probably because of the neuropathy instead. Sometimes, as you see in diabetic plexopathy, they got severe tenderness in the muscle. So the localization is okay, like femoral neuropathy. So what investigation you need now?
Proximal NCA study, sir.
Okay. Before that, we did this thing. MRI was done. We found hyperdensity in the cortices muscle. You can see there. See, remember this right is on this side, unlike CT. They have to keep that mind in mind. What you see, the hyperdensity is the left corticeps. Again, but you find that not only in the left corticeps, the right side corticeps also has got hyperdensity. So this is completeness on the left side, but you got hyperdensity in the right corticeps, vastus lateralis also. The left side is slightly hyperdensity, which you can make out now compared to the right side. That is on the right, not on the left. The gluteus maximus also showed hyperdensity. That is on the same side of the affection now.
CPK, sir.
I'll come to that. So this is hyperintensity in the muscle. This is on the right side. So in fact, even though accompanied pain and weakness on the left thigh, there is hyperintensity seen in the other muscle on the other side also. And that side is asymptomatic. It has no tenderness, no weakness. This is the video. Again, you can find out the hyperintensity on the right side, apart from the left side also. So patients thought a left neuropathy plus muscle edema. That is the thing which I thought. Maybe subclinical involvement of other nerves or associated inflammatory myopathy. Why the other thing got in? So what do you like to do now?
CPK, sir.
CPK normal. I'll come to that later. I'll show the values. But already we got evidence of neuropathy. Yes, rank check is absent, sensory loss is there.
So the muscle edema may compress on the nerve and cause compressive neuropathy.
But edema is not, no, edema is not that much. It's not much of edema at all. Tenderness is there.
EMG.
Okay. Somebody asked for CPK. I'll come to that later on. CPK was normal. But EMG is also going to help. Anyway, you got a neural involvement is there. Weakness of the muscle is there.
You're telling myopathy, no? So
yeah, in addition to that, okay. In addition to the neuropathy on the right side. Okay. So, in fact, I thought a plexopathy in this patient. I put him on IV MP for 5 days, followed by oral steroid. So he came for send the patient home, and he came for follow-up after 2 weeks. In fact, he has got remarkable improvement in the left-sided pain and weakness. Reflection was normal. Reaction still weak, but less than before. Reduction was normal. Hip extension normal. All of the, just like before, the hip flexion improved. Knee extension slightly weak. The left knee jack continued to remain absent. And knee jack normal. Area of sensory loss diminished. That area was initially affected, now it's become better. There it became, initially it was the lower, up to the lower thigh. The pain subsided. The reverse cellular was also much less pain, no pain at all. Mild pain. Initially it was screaming with pain, now it has become decreased. So follow-up examination, pain has remarkably improved. Weakness of the hip flexion totally improved. Partial improvement in the left quadriceps. He was able to walk unaided. Initially he was not able to walk without support. Left knee joint continued to be absent. Area of sensory has shrunken. Now, this story does not end there. I was about to send him off when he volunteered another complaint. He said he could not eat food with his right hand properly. In fact, I have sent him out of the room. Then he came back again, told me, sir, I got one more problem. What problem? I got wild because I already spent time on him. Then I saw him. He said I could not eat with his right hand. Then I started examining once again. He could not exactly tell. I asked him how long he had the problem. He cannot tell because he was all the time under sedation because of his agitated behavior. Since he was in sedation most of the time for his aggressive behavior after stopping drugs. When he came to the sensorium, he does not remember he is having his weakness right side. That is why he did not complain. When I asked him, was it there initially? He was not sure. He said it could have been. I do not know. When he started eating with the start right hand only, he noticed his problem. He could not lift up his hand to the mouth in the usual way. He has to take his upper limb outward and then was able to elevate, reach the mouth. I'll show the picture. He complained of no pain. This is the way he would eat. Listen to him. He said he could not take the food like that. You know, take it to the mouth. Try maximum try. He could not do it. This is the way he eating. He's abducting the hand and then bringing it to the mouth. He cannot bring the ophthalmos like this, but he could, while abducting, he could take it to the hand, to the mouth. So which muscle is weak to produce this type of a trick movement to circumvent this disability?
Supinatus.
Not
Elbow
supinatus.
flexor, sir.
No, elbow, okay, you can call it elbow flexes, but he is able to flex. But he is doing, when you lift it, abduct it, you would be able to do that. I'll show the video once again.
Anti-fibers of filter.
Okay. Try maximum try. But when you abduct it, he is able to do that.
Break it.
Yeah. No, this is not. What is his problem? He is not have a forward flexion of the shoulder. Okay, his abduction is good, but forward flexion shoulder is affected. That means his flexion of the shoulder is affected. That means coracobrachialis, and as you said correctly, anterior fibers, the delta, there are flexes in the shoulder. That must be affected to produce this kind of it. So what does he do? He abduct the shoulder and then bring it, because he can, against cavity is eliminated, he can bring the hand towards his mouth. Okay, have you followed what I said? Because you bring it down, so he abduct and then can flex the because eliminating the gravity. And this is the, and of course anti-fibers deltoid is also there. So examine him again, since he's got a fresh complaint. So now examination shows neck muscles normal, shoulder elevation normal, deltoid is normal bilaterally, flexion was normal, triceps normal, coracobrachial is weak on the right side, recession normal, finger pressure is normal, and he had got significant weakness of the external rotate, supraspinatus, infraspinatus. I'll show that. Serratus anterior scapular muscles normal. Rhomboid is normal. See, the external rotation is markedly weak on the right side. Then supraspinatus is also weak on the right side. Come with the reflexes. Biceps, supinator, triceps are all normal. Sensations normal. Okay, so what is the setup? What is the diagnosis now? Right? So try.
Brachial plexus.
Yeah, maybe brachial plexopathy, the right side. In addition to the left plexus, right side is also getting involved. That's what I thought. It are all normal in the upper limb, since it's normal. Now to explain this, I already told you. No, brachial plexopathy was the thing I considered. So what is the cause now? Has potassium steroid is thigh improved? In the upper limb did not improve, or whether improved partially, we do not know. So neurology chemometry was, yeah, anyone please?
Idiopathic chemometry.
Yeah, idiopathic. Right.
So because of restraints in the ward when he was admitted.
No, that's very unlikely because if the nerve affected is the suprascapular. So that if you would restrain, if you suppose a tourniquet around the shoulder and this thing, I mean the arm, you can involvement of the root of the brachial, not the root, the cord of the brachial plexus can be affected. You've got a pulling, if you heard somebody is pulling the hand below, you can stretch the brachial plexus. But only isolate suprascapular nerve involvement. If somebody is falling onto the shoulder only, put weight on the shoulder only, like a rucksack, they can put a suprascapular nerve. Not by restraint, it will not be very unusual to produce.
Okay, sir.
So what test will you do? So nerve conduction was done. That is normal. The supraspinatus also is normal. CMAP update on the supraspinatus infraspinatus normal. So could it be rotated cuff injury? There is a thing I had in mind. So what will you like to do now? Yes, got weakness, but conduction is normal.
MRI.
Yeah, the thing is, see, when you got somebody has got a weakness, significant weakness, you find conduction normal. What will you suspect? You have to think of the weakness may not be a real weakness, maybe like rotator cuff injury. Suppose the muscle is pulled up when detached from the tendon, detached from the bone, you cannot conduct the muscle. At the same time, nerve conduction will be normal. It will conduct when the nerve is stimulated. Are you getting my point? See, he has got significant weakness, but at the same time, CMAP amplitude in the infraspinatus, supraspinatus is normal. Are you following me? Are you not hearing any sound?
Yes, sir, but pain
Yeah.
will be there.
Yeah, pain may not be there. Injury pain may not be there. See, this all happens when you're doing the fall. That there may be there, that may not cause much pain at all. Maybe there, may not be there.
Okay, sir.
So what test will you do to find out that thing?
MRI, shoulder
MRI.
joint, sir.
He does not remember. I asked about any fall. He does not remember any fall. He fell down on the right shoulder because of this, since EMG is normal. So one can only rely on history since he was agitated and he was showing violent behavior in the de-addiction center. So then I did an EMG to find out that curiously, I have no potential picture from the EMG. My needle is not entering into the muscle. Somewhere else entering, I don't know. I was surprised why I'm not picking. Even if it is a rotator cuff injury, the muscle, there will be some potential be picked up. Occasionally, there's only that is there, otherwise, no activity is there. I do not know what. So, curiously, I could not get an EMG potential. I was not sure whether it was my wrong technique or rotator cuff injury. So, MRI was done to rule out a rotator cuff injury. This is the MRI done. There is no real rotator cuff. Mild, this is very insignificant rotator cuff. No, nothing, no tear at all. You know what would you like to do?
So there was muscle enhancement in the unaffected right quadriceps, sir. So
Correct.
what about the muscle MRI of upper limb? IBM can be considered here.
Very good. I don't know, IBM is it's an acquired thing. So very good. That's the thing you have to keep in mind. So there is something is happening there in the. So what is it? So the MRI was done. Because I was not able to explain why this is occurring, why the EMG is not getting. So this is the MRI. See what is actually click at the MRI now. The suprainfraspinatus, there is some abscess-like thing. There's no pain at all. See what is happening. Something like a diabetic myonecrosis. See? That is in the infraspinatus.
Pachyerus of muscle edema പോലെ കാണുന്നത് നമ്മൾ ഇൻഫ്രാസ്പൈനറ്റസ് ടീരിസ് posterior deltoid.
No, what is? Pardon? Muscle imaging. That is you get something like a hypointensity in the center surrounded by hyperintensity due to edema. If you have seen myonecrosis in diabetes, it's exactly same appearance which you see in myonecrosis. But he never complained of pain in the right shoulder. Only weakness was there.
Whether alcohol can cause this type of myopathy, sir?
Okay, that's a good thought.
HIV, sir?
HIV was not, it was negative. But I'll tell you the story, I'll tell you. He was followed up after steroid. This also improved. Not a full extent, but much better than before. Sorry, mild improvement, no significant improvement. Now, what does MRI suggest of? Then I asked about the all drug history. He has been taking MDMA for 2 years. And you know the country where it is getting from, you're surprised it is from Abu Dhabi. So I did not know this drug can cause myonecrosis. I never knew. Nobody knew also. The radiologist also not knowing whether it can produce. So this is the report. Heterogeneous signal intensity peripherally enhancing areas involved infraspinatus, teres minor, posterior deltoid fibers, likely representing inflammatory more than infectious myositis associated with myonecrosis. Possibly personality syndrome less likely. Possibility is less likely. More likely to be some toxic or something drug-induced. So search the literature, you find there is rhabdomyolysis in methamphetamine, amphetamine, MDMA use. And this is the frequency of rhabdomyolysis in patients scanning positive. MA means this thing, MDMA, plus 20%. These things. So that's the story of the patient.
Can it be due to any intramuscular injection, sir?
Pardon?
Could it be due to any intramuscular injection taken long back?
No, very unlikely, because injection given in the deltoid, no, it is in the supraspinatus and infraspinatus, and it is not an abscess at all. It has severe pain, there is no pain.
Then the lower limb also could be due to that only, sir.
Maybe. Also, that's what I'm thinking. But he has got nerve involvement in the thigh involvement, not only myonecrosis, nerve is also getting involved.
So CPK, why was not elevated, sir?
It was not elevated because I don't know why. If it is a diffuse involvement, it can be elevated. A localized involvement of one muscle may not be involved. I don't know. See, even in inflammatory myopathies, for example, in dermatomyositis or in 30 to 40%, even with CPK may be normal, even with the pain and tenderness of the muscles.
So can we consider other muscle enzymes like aldolase level?
Yeah, that can be done. Because I had previously during the COVID season, I had 2-3 cases of diabetic myonecrosis, which I presented here. That patient also CPK was wrong. Typical myonecrosis like this. That patient severe pain and weakness of the quadriceps and improved ultimately with steroid. Yeah, but that CPK was wrong. Okay. The lesson is that in these people nowadays, the people consuming these drugs is very high. We do not know they may be consuming these drugs. So you have to keep this possibility in the back of the mind. Always ask a drug history. Okay, any questions? I am seeing for the first time myonecrosis induced by MDMA. In fact, I had not seen any complicated MDMA before. Any other case also I had not seen. Okay.
Shoulder MRI, there were no findings to suggest this.
No finding. There was no tear. There was no tear in the tendon, except this hyperintensity in the muscle and the necrosis of the muscle. Initially, I thought only brachial neuritis to account for the shoulder weakness. Typical distribution of the brachial neuritis. But the MRI came as a sub. MRI was taken to rule out a tear, but it came as this finding. Okay, shall we close?
Yes, sir.
Yeah. So
Thank you.
see you next week, same time. Good night. Good night.
Nice.
Good night.
Good night, sir. Thank you, sir.
Good night. Thank you all.
Thank you, sir.